Rushi, and thanks everyone. We're excited to have Rushi today talk about transplant vasculopathy, something we're very familiar with, and Rushi's done some great work on that with his recent AHA grant, looking at this. Without further ado, Rushi, looking forward to your talk.
All right, thanks, Ali, again for the invitation.
If you could just talk about a little bit more.
Say it again.
Your volume up a little bit more.
Is this better?
Yeah.
Okay. So thank you again for the invitation. The title of my talk today is Cardiac Allograft Vasculopathy and the Therapeutic Potential of Endothelin 1, an old dog with new tricks. These are my relevant disclosures. So the agenda for the talk today, first, we're going to review temporal trends in heart transplantation and where the current landscape stands today. Next, we're going to briefly dive into the pathobiology and invasive imaging of cardiac allograft vasculopathy and review the sobering data that illustrates why it's indeed the Achilles heel of heart transplantation. Next, we'll shift gears and review the intriguing early animal and human data related to endothelin 1. And finally, I'll share my journey with endothelin 1 and CAV to date. So first, let's discuss temporal trends in heart transplantation. So the birth of heart transplantation was on December 3rd, 1967, when Dr. Christian Barnard and colleagues performed the world's first human-to-human heart transplant at the Groote Schuur Hospital in Cape Town, South Africa. And this, of course, was a monumental occasion. As you can see here, he is gracing the cover of Time magazine, him and a nurse, along with the patient, on the cover of Life magazine, which were the two biggest magazines at that time. And it even made the front page of the Los Angeles Times the next day, in addition to this cable car accident, apparently. And, you know, the following month, January 6th of 1968, Dr. Norman Shumway performed the first adult heart transplantation in the United States at Stanford. And, you know, those two together kind of dawned the era of heart transplant, and it officially took off. So these are ISHLT data showing the total number of heart transplants globally over the past 30 years or so. Approximately 90% of these are in adults. And as you can see, the overall frequency of heart transplantation basically has plateaued over the last few decades at around 5,000 per year, the majority being in North America, then Europe, and then other parts of the world. More recently, in 2016, 2017, there's been a slight uptick to nearly 6,000 annually, owing to more numbers in North America. These data show the average transplant center volume worldwide. There's nearly 350 centers globally, about 150 of them in the United States. Here at UCLA, I think most of you know, we typically perform about 50 to 70 total transplants annually. A number of those are high-risk dual organ transplants, about 10% also in non-adults. And that kind of puts us at the forefront here as a top 10 center worldwide by volume. So something to really be proud of for Ali and the rest of the team. And this kind of gets at where we are today in terms of survival. We've come a long way since the first transplantations by Doctors Barnard and Shumway. You know, their patients unfortunately died within the first 2 to 3 weeks after surgery. Today, the median survival is 12.5 years. And if you survive to the first year, then the median survival is nearly 15 years. And as you can see here in the purple versus the blue curves, the 5-year survival in the contemporary era is 75% compared with 63% about 3 decades earlier. However, you know, despite this overall progress, cardiac allograft vasculopathy, or CAV, really remains the Achilles heel of heart transplantation. I'll get into the relevant survival data in a few slides, but I first wanted to briefly review the pathobiology of CAV. So as depicted in this cartoon here, CAV is a complex disease of the graft coronary arteries defined by diffuse early intimal hyperplasia, which is due to smooth cell proliferation and matrix deposition, And this is really similar to the pathobiology of in-stent restenosis. It's also caused by negative remodeling, which is vessel shrinkage and lack of compensatory remodeling due to increased medial tone and adventitial fibrosis. And together, these dual processes of intimal hyperplasia and negative remodeling lead to an accelerated luminal obstruction of the epicardial and microvascular coronary circulation. So this is what severe CAV looks like on coronary angiography. Quick shout out to one of our star fellows, Dr. Nagin Shahande, for leading a state-of-the-art review of contemporary invasive imaging modalities for CAV, from which this figure and subsequent figures are taken. You can see here the classic distal pruning and beaded appearance of severe angiographic CAV. This is the right coronary artery and the PDA and PL branches. In this panel, you can see again the severe disease distally with distal pruning of the LAD, as well as of the diagonal. And here you can see a CTO of the OM, of the circ, I should say, and then severe disease of the OM here. And this is in a patient who a lot of you on the call may know of. This was just 8 months after transplant. And so coronary angiography has been the gold standard for the invasive diagnosis and screening of CAV, and it carries a class 1 recommendation post-transplant. And that's why we cath these patients usually for at least the first 3 to 5 years. However, although angiography is widely available and provides valuable prognostic data, there are limitations regarding its sensitivity for detecting early CAV. As you know, angiography really only assesses the lumen of the epicardial coronary arteries, and it does not really provide imaging of the vessel wall. And so, as mentioned earlier, since CAV is more likely to result in diffuse concentric intimal hyperplasia and negative remodeling, this may not be recognized on angiography until late in the disease process, which poses a problem. And so given these limitations, more sensitive invasive modalities have been used to screen for CAV, with intravascular ultrasound or IVUS emerging as the standard of care for CAV surveillance in the current era, in light of its ease of use and robust outcome data. And so through cross-sectional imaging of the lumen and vessel wall, IVUS provides greater sensitivity in screening for early onset CAV, not yet detectable by conventional angiography. And so you can see in this figure here of the LAD, the discordance between angiography and IVUS. The LAD here, I think most of you would agree that looks like it's pretty good or only has maybe mild disease. Whereas on IVUS, you can see significant intimal hyperplasia and plaque thickening in the proximal LAD. This right-hand panel kind of gets at the whole pathobiology of what's going on in CAV. So this is angio at baseline in 1 year, and sorry for the small figures, but hopefully you can see that there really doesn't look like much of a change angiographically. But when you look on IVUS, you can see that there's a change from baseline to 1 year, both in intimal thickening. The max intimal thickness has increased quite a bit, as well as vessel remodeling. So the actual vessel volume or vessel area size, I should say here, is smaller than, is larger here than here. It's actually decreased in size. And so that's the paradoxical remodeling that can happen with CAV. Just to quickly talk about some more emerging technologies, the addition of OCT or optimal coherence tomography and near-infrared spectroscopy or NIRS to the imaging armamentarium has allowed for more detailed plaque characterization than IVUS can allow for, and shed further light on the mechanisms. However, it should be noted that these imaging modalities currently are lacking outcome data and thus are primarily used for research purposes. So on this left-hand panel, you can see a comparison of what you would see on OCT versus IVUS for the same segment here in the proximal LAD. And you can see that OCT really provides near histologic visualization of the intima and the plaque. And so you can see a fibrotic plaque here, a lipid-rich plaque here, a thin cap fibroatheroma, and then macrophage infiltration here in panel D. You don't get that with IVUS, but what you do get with IVUS is deeper penetration into the vessel wall, so better visualization of the intima and media interface. This panel here shows near-infrared spectroscopy, which is overlaid on IVUS, and this is what we call a chemogram. And basically, sorry about that. Basically, what we see here is that here in the mid-LAD, there's a lipid-rich plaque as detected here on near-infrared spectroscopy. And there's interesting research going on targeting these types of lesions with heavier duty lipid agents such as PCSK9 inhibitors. So now shifting gears, the sobering long-term survival data related to CAV has led to it being coined by Chi and colleagues as the Achilles heel of heart transplantation, a term I really think is fitting. And so as you can see here over time, this is from 95 to 2018, CAV doesn't result in much death in the first year after transplant, but afterwards, from year 1 onwards, it's 10 to 12% of death for over the last 2 to 3 decades. And even if you just look in the contemporary era from 2010 to 2018, you can see here in red, CAV again is responsible for about 10% of deaths in the modern era. We also know that from landmark studies done in 2005 that accelerated CAV just even 1 year after transplant, defined on IVUS as a change in maximal intimal thickness by greater than 0.5 millimeters, is a major predictor of all-cause mortality at 5 years. This first study was actually led out of UCLA by Drs. Kabashigawa and Dr. Tobis, and involved five centers, including Stanford, Cleveland Clinic, Emory, and Oceaner. Only 125 patients, but pretty impressive data. And this was corroborated by another study out of the Cleveland Clinic that was just a single center study, slightly more patients, 143, again showing a significantly increased mortality rate in patients with greater than 0.5 millimeter change at 1 year. Now, a few words about the incidence. Unfortunately, despite advances over the past few decades to prevent and slow the progression of CAV, which includes the advent of statins, robust immunosuppressive agents to treat acute rejection, and aggressive infectious prophylaxis, the incidence has only marginally improved. Here, as you can see, the green curve is the prior era and the red curve is the more contemporary era. And the incidence of CAV at 5 and 10 years has only really improved slightly from 32 to 30% and then 52 to 49%. This is some interesting data led by another one of our star fellows, Dr. David Tarani, looking at the impact of the new UNOS donor allocation system on the incidence of CAV. What he looked at was the new allocation policy that was implemented in October 2018 that prioritizes hemodynamically unstable patients with shorter waitlist times. And so we did a retrospective analysis of nearly 9,000 adult heart transplant recipients, single organ, who were registered in the UNOS database from 2015 October to November 2019. One caveat of the UNOS database is it only provides or captures angiographic data and IVUS isn't captured. What we found was that the new allocation system was significantly associated with a reduction in accelerated angiographic CAV at 1 year. The adjusted odds ratio was 0.73 with a p-value less than 0.01. And more importantly, this association persisted even after restricting the cohort to the highest acuity patients. So that would be in the old system, status 1A, and in the new system, status 1 or 2. And both of these were about 50 to 60% of the patients of the overall population. Again, the adjusted odds ratio is 0.7 here with a p-value of 0.01. The mechanisms for these findings and the long-term implications are unclear and are going to require further investigation, but very interesting data to say the least. And then this slide really gets to the survival once you've been diagnosed with CAV and unfortunately how poor it is. So similar to the incidence rates, CAV-related survival is only slightly improved in the contemporary era, despite the previously described therapeutic advances. These ISHLT data reflect survival after the first 3 years, if you've been diagnosed with CAV within the first 3 years after transplant. And as you can see from the red and blue curves here, this is comparing in red the old era to the new era in blue. the 5 and 10-year survival rates have only modestly improved from 72 to 78%, and then 49 to 55% at 10 years, respectively. And in addition, when you compare to the yellow curve, for example, in the modern era, to patients who don't have CAV, those with CAV demonstrate a poor prognosis, and it looks like the curves are separating as time goes on. And so I think collectively, these data for me highlight that the clinical care of heart transplant recipients in the contemporary era is greatly limited by a lack of targeted, effective treatment options to prevent and or slow the development of CAV. And that there's a critical need to better ascertain the mechanisms of CAV in order to generate new therapies and meaningfully impact outcomes. So now shifting gears, I'd like to talk a little bit about endothelin-1, which is a potential mechanistic target in the pathogenesis of CAV. So endothelin-1 is a key molecular mediator of vascular homeostasis with potent vasoconstrictive, mitogenic, and pro-inflammatory effects throughout the vessel wall. It is mediated by two receptors, the ETA and ETB receptors. The ETA receptor mediates vasoconstriction, proliferation, and fibrosis. And the ETB receptor is a little more interesting. It actually causes vasodilatation amongst endothelial cells, but performs more like the ETA receptor, I should say, with smooth muscle cells, leading to vasoconstriction. And importantly, endothelin-1 carries immediate therapeutic potential, given that endothelin receptor antagonists are already clinically well established in the pulmonary arterial hypertension arena, and they have a very favorable safety profile without any significant drug-drug interactions with standard post-heart transplant pharmacotherapy. So I just want to take you down through some of the seminal animal and human studies that have transpired thus far. The first study by Okada and colleagues, and they used rat cardiac allografts, showed discrete endothelin cellular immunoreactivity in both the neointima and media, shown here in panels C and F. And then what they did was they administered oral bosentan, which is a non-selective combined receptor antagonist of endothelin, for 120 days to these rats. And as you can see here in panel H, it significantly attenuated the development of CAV. Next is a series of studies by Simonson and colleagues that provide further evidence for the role of endothelin-1 in the pathogenesis of CAV. So in this study, the authors treated rats with an ET1 converting enzyme inhibitor as opposed to a receptor blocker. And you can see here in panels A, C, and E, which are the control panels, you have intimal hyperplasia, increased medial tone and adventitial fibrosis here in blue, and macrophage infiltration here with these arrows. And then after administration of this endothelin converting enzyme inhibitor, all of these changes are attenuated. This group in a subsequent study then looked at outcomes. And so they compared rats who received placebo, those who received cyclosporin, phosphoramidine is the endothelin converting enzyme inhibitor, so those who just received that alone, or the combination of cyclosporin and phosphoramidine. And what they found was that in panel A in the controls, there was severe vasculopathy, and that just administering cyclosporin alone didn't change that in panel B. However, in the rats who received the endothelin converting enzyme inhibitor, you can see a marked reduction in vasculopathy, but there's still evidence of rejection here, but that is attenuated when you have the combination therapy. And you can see here in the Kaplan-Meier curve that mortality or survival was much better with combination therapy, but even just the endothelin the endothelin converting enzyme inhibitor alone provided substantial benefit compared to control, and even better than cyclosporin alone. So moving on to the early human experience, which is fairly limited, the first study began with a small study by Ravalli and colleagues, and they just looked at explanted allografts compared to normal native hearts. And what they found was that compared with explanted native hearts with normal coronaries, which is here in panel A, The explanted allografts in panel B exhibited significantly more endothelin-1 immunoreactivity throughout the vessel wall. The next study was a really interesting study by LaRose, Peter Gans, one of my former mentors and colleagues at UCSF. And what they did was they compared 10 patients with advanced CAV, which they defined as greater than a 15% stenosis on QCA, or quantitative coronary angiography, to 8 patients without CAV. And they administered in the cath lab an IV selective ETA receptor antagonist called BQ123, which is no longer available to give in humans. But when they did this study, you can see here on the right-hand panel, this is the infusion time of BQ123, and this is the percent dilation of coronary artery segments. And you can see here on this curve, in patients with advanced CAV, there is significantly more dilatation compared to controls and those without, vasculopathy. And then really in those with this, if you look at the stenotic segment, there's a significant amount of dilatation. And then they also did an interesting thing where they compared the amount of dilatation to the gold standard, which is intracoronary nitroglycerin. And what they found was that 13% of the vasomotor tone in controls was mediated by endothelin. But in patients with advanced CAV, and especially in the stenotic segments, it was over 50%. So this was really the first study, and only study, truthfully, that really showed the biological activity of endothelin-1 in transplant patients. More recently, Starling and colleagues looked at plasma ET1 levels and their association with accelerated CAV at 1 year on 2-dimensional IVUS in 106 patients. And what they found was that the change in endothelin-1, but not the baseline level. So this is a level drawn during their first index catheterization, usually in the first 4 months of transplant, and then an endothelin level at their 1-year cath. And they found that that change was significantly associated with accelerated CAV. So the higher the change in endothelin-1, the more accelerated vasculopathy they found on IVUS. So to sort of summarize this initial data, the animal data provided causal evidence for ET1 in the pathobiology of CAV and confirmed that it exerts effects throughout the entire vessel wall. And human studies are consistent, but there's a few key limitations that should be noted. First, obviously very small sample sizes. Second, using less sensitive techniques to evaluate the coronaries, namely angiography and 2D IVUS. Third, they really only evaluated intimal thickening and failed to assess vessel remodeling. And fourth, there was a lack of outcome data. And so that kind of brings us to my journey with endothelin and CAV. So building on this prior literature and funded by a grant from the Heart Failure Society of America, my colleagues at Stanford and I performed a retrospective study examining the relationship between plasma endothelin levels and accelerated CAV on 3D volumetric IVUS, as well as long-term heart outcomes, death or retransplantation, among 90 heart transplant recipients at Stanford from 2002 to 2014. And landmark 2D IVUS studies that I mentioned prior, the one with Dr. Tobis and Tuscu et al., reported 20 to 30% rates of accelerated CAV at 1 year based on maximal intimal thickening. And so we selected greater than the 75th percentile to correspond as the cutoff to define accelerated CAV, which we defined as lumen volume loss, and then its dual components, intimal hyperplasia, which was plaque volume gain, and negative remodeling, which was vessel volume loss. What you can see here is that in patients who have CAV, accelerated is in red and non-accelerated is in blue. They have higher baseline endothelin levels here in the accelerated group. And that's mainly driven by negative remodeling. So the patients with accelerated negative remodeling also had higher endothelin levels. The ones with accelerated intimal hyperplasia had similar levels to those without. This is a ROC curve showing that the level of endothelin at baseline that best that has the best diagnostic accuracy for accelerated CAV is 1.75 picograms per milliliter. And this had an AUC of 0.69 and a sensitivity of 73%, specificity of 68%. And this is sort of a scatter plot of all the values. And you can see here in blue, the ones that are above this 1.75 cutoff, the majority of patients with accelerated CAV have endothelin levels that are above that cutoff. And what we did is we did multivariable analysis, adjusting for recipient and donor demographic and cardiovascular risk factors, as well as transplant-related factors. And we found that baseline endothelin levels and statin use at 1 year were the only independent predictors of accelerated CAV at 1 year. And for baseline endothelin, this was an odds ratio of 2.13 with a confidence interval of 1.15 to 3.94 and a p-value of 0.01. And this persisted, of course, when treating ET1 as a dichotomous variable at that cutoff of 1.75. Odds ratio, of course, went up owing to the decreased power by dichotomization. And this, again, was driven by a strong trend towards accelerated negative remodeling. This didn't reach statistical significance, but was a strong trend for baseline endothelin levels leading to higher rates of negative remodeling. And then again, there was no association statistically between baseline endothelin levels and intimal hyperplasia. These are the outcome data. So you can see here that we had a median follow-up of 4 years. The IQR was 2.5 to 10 years. There was 18 deaths out of 90 patients and 0 retransplants during that time. And as you can see here, again, those with an endothelin level greater than 1.75 had worse survival compared to those without. This had a hazard ratio of 2.94 and a p-value of 0.02. Now, of course, I need to highlight some of the limitations of this data. First and foremost, this was a retrospective analysis and non-consecutive data. The reason for the 12-year span in patients was who we had banked blood samples on from 2 prior clinical trials that had taken place at that institution. There's also non-uniform immunosuppressive regimens across the areas, which we, of course, accounted for statistically, but still leads to a lack of generalizability. And then there was a lack of serial ET1 data. So we only had banked blood samples for baseline and not 1 year. So we weren't able to look at the change in endothelin levels. And so my conclusions from this paper was that baseline endothelin 1 appears to delineate risk for accelerated CAV and provide durable prognostic value among heart transplant recipients, and that prospective studies are needed to externally validate these data. And so building off this retrospective data, I was fortunate to receive a Career Development Award from the American Heart Association to study this prospectively. And so this study, as the fellows know, is using contemporary interventional modalities to prospectively and comprehensively define the role of endothelin in the development of accelerated vasculopathy in adult single organ heart transplant patients. We're measuring endothelin levels at baseline and also at 1 year to assess the change. From an anatomical perspective, we're doing 3D IVUS along with looking at lipid accumulation via near-infrared spectroscopy. We're measuring coronary physiology using fractional flow reserve, and this is of the epicardial coronary circulation. And then we'll also be doing coronary vasomotor function testing using macitentan, which is an oral endothelin receptor antagonist, and comparing it to intracoronary nitroglycerin to look at the dilation ratio. And so I just want to give a current snapshot of where the study stands. So we started enrolling in early January 2019, and thus far we've enrolled 77 adult single organ heart transplant patients, and we have about 5 more in the next 2 weeks. 30 thus far have been excluded, 21 have been dual organ and thus are excluded. 4 weren't able to get their baseline visit due to renal dysfunction. 3 repatriated to other countries or other institutions, and 2 unfortunately passed away. We've only failed to enroll 7 patients, and this was the growing pains of learning how to run a prospective study. The first 6 months we for logistical reasons, basically failed to approach 6 patients who got scheduled without our knowing. And then only 1 patient thus far in over 2.5 years has refused consent. So far, 54 participants have completed the 1-year window. 6 did not undergo 1-year studies, again, 3 due to renal dysfunction and 3 due to repatriation to other institutions or other countries. And then 12 have had incomplete either baseline or 1-year IVUS data, and that's due to both operator failure, which is either A, forgetting to do it, or not assessing a long enough segment of the LAD, wiring challenges, or vasospasm. And then unfortunately, 5 or 6 have had unanalyzable data, and that's due to using other IVUS platforms or unfortunately corrupt imaging files. So this sort of the trials and tribulations of doing research. We're sending all of this data to the Stanford Imaging Core Lab, who's doing a blinded imaging analysis, and that is underway now that we have a reasonable sample size to start analyzing here in the next couple months. And as I think everyone knows, unfortunately, this work, like most of everyone else's work here at UCLA, has been stalled by COVID-19. We had an approximate cumulative 6-month delay due to cessation of elective post-heart transplant caths during both the first and second surges. And then, of course, on top of that, the impact of COVID-19 on donor availability initially, and just transplant volume. You know, initially when COVID first hit, we were restricting transplant to only the sickest of patients because we didn't really know what the impact of COVID would be on this population. And so due to that, I'm hoping to receive a COVID supplement award from the AHA to extend this work due to this delay. I also mentioned the Macitentan arm of the study. I hope that begins in the next couple months. What we're going to be doing is a consecutive subset of patients will receive a 1-week course of Macitentan prior to their 1-year visit, and we'll be studying the vasomotor tone using IVUS and comparing it to nitroglycerin. You know, unfortunately, this grant, Janssen's going to be providing the Macitentan right now is being held up in contracting disputes between UCLA and Janssen, but hopefully that gets resolved here in the next couple months and we can begin this part of the study. And then finally, barring any other further setbacks, I expect to enroll 105 to 110 patients by the time we close enrollment in December. And that'll be just above the anticipated sample size of 100 patients. And so I feel like I need to give a special thanks to all the fellows who've scrubbed with me over the last 3 years and helped me with this study and been super enthusiastic about doing these cases, which can be somewhat laborious at times. I totally get it. And, you know, my future directions are that if these data are favorable, I hope to submit an R01 to conduct a pilot randomized placebo-controlled trial to assess how endothelin receptor antagonists impact the development of accelerated CAV. And this will be a sort of multi-pronged invasive approach of, again, looking at coronary anatomy using volumetric IVUS, looking at plaque composition using near-infrared spectroscopy and OCT, and then coronary physiology using both FFR for the epicardial circulation as well as the index of microcirculatory resistance, or IMR, to look at the microvasculature. And so these are my take-home messages for the talk. Again, CAV, I hope you guys are convinced now, is the Achilles heel of heart transplantation with only modest improvement in incidence and survival in the modern era. There's accumulating data suggesting that ET1 may help risk stratify accelerated CAV and hold prognostic value, and it makes it a compelling therapeutic target. And that the potential addition of ERAs to the limited CAV armamentarium would be a quote unquote new trick for an old dog and signify a pivotal shift in the clinical practice of this complex patient population. And last but not least, I think I really want to highlight that research is a team sport. So I want to just personally thank everyone on this slide. First here at UCLA, Doctors Fonero, Tobis, DeVay for giving me a lot of support when I joined UCLA in 2018 to carry out this study. Dr. Tobis especially, who allowed his research coordinator, Ruby, who I couldn't find a picture of, so I apologize for leaving her off the slide, to help me get this study off the ground. Special thanks to Ali and the heart transplant team for really welcoming me and opening the heart transplant population to this study. And then sort of the bedrock of the study, Danielle, I don't know if she's on, she's my study coordinator and she does all the nuts and bolts and wouldn't be able to do this without her. This is Lisa Bang and Juka Kim. Lisa is a UCLA undergraduate who's actually applying to medical school this year, and Lisa is a rising, or sorry, Juka is a rising MS2. Both have helped with data entry and analysis. And then, as I mentioned earlier, David and Nagin, two fellows who've really worked with me on CAV in this project and other CAV-related projects. And then I have to give a special thanks as well to my mentors at Stanford, Bill Fearon, who's interventional cardiologist interested in CAV, Karen Cush, who's the heart transplant program director at Stanford and involved in a lot of CAV research, and then Yasuhiro Honda, who's the head of the imaging core lab at Stanford. And so with that, I want to thank you everyone for your attention and happy to take any questions.
I have a question. It's Holly.
Hey, Holly.
Hey, great talk. Thank you so much. Can you tell us a little bit more about the biology of endothelin 1? Where does it come from? What's the stimulus for its secretion? Are the plasma levels reflective of what's going on in the vessel?
Yeah, great question. So let me go back here. So, you know, just similar to nitroglycerin, endothelin is sort of the, as you know, the counterpart to nitroglycerin. And so whether it's through inflammation or immune mediation, that stimulates endothelial cells to release endothelin. And so when I didn't include that data, but when you have certain endothelin levels, that's correlated with endothelial tone. So in patients who are on endothelin receptor antagonists, their levels, for example, will still be the same. It's just, you know, of course, that action is not being mediated.
So it's inflammation in the blood vessel that's stimulating the endothelial cells to secrete it, or do we know?
Yeah, that predominantly.
Are similar findings seen in lung transplant rejection?
You know, I actually don't know about lung. Obviously, in the pulmonary hypertension space, this is why it's used, but I do not know if it's being used or looked at in lung transplant rejection. That's a good question, Henry. I'll have to take a look.
Great talk, Rushi. Thanks. And again, Rushi's done terrific work with our group on transplant vasculopathy. So it's very exciting, and we're glad he's part of the team working on this. Is there any thought on looking also, this question for you, more comment, looking at the immune status of patients? Because there's other predictors of vasculopathy, AMR, infections such as CMV. Now there's concern, or at least thought about Hep C positive donors. There's some concern of accelerated vasculopathy there, kind of correlating as well their immune status data along with like an immuno-West test and history of rejection to add that, kind of have a little more of a comprehensive look at triggers for rejection and vasculopathy.
Yeah, that's a great point, Ali. So as you mentioned, things like graft ischemic time, history of acute rejection during the first year, you know, lack of using statins, have all been shown to lead to accelerated vasculopathy. And more recently, using Hep C donors, I think that's a new sort of era to look at. And I think your thought of combining all these different high-risk features maybe into like a risk model or something like that, it would be a good study to pursue.
Yeah, and as you said, it's an immune process that that's you know, triggering this, and you know, it's an underlying low-level rejection going on with interaction between your humoral system and your endothelial system that can trigger this you know, endothelialization and vasculopathy, and just different rates. You know, highly sensitized patients too. We do see a lot of highly sensitized patients. We all know here that we desensitize them. So I think looking at the immune process as well, and in parallel with this, would would lead to some new insights, hopefully.
Yeah, and I think a couple things I didn't mention. One is, possibly looking at, right now, most of these studies have looked at baseline quote unquote endothelin levels really aren't baseline. They're just 3 to 4 months after transplant. And so there's probably utility in trying to look at endothelin levels sort of at the time of transplant or within the first few days and see how endothelin levels change over time, and does that at all predict accelerated vasculopathy and or outcomes. And so lots to look at in this space, and hopefully some of the fellows who are on the call are percolating with ideas, and we'll be happy to pursue some of these questions with the team.
Rushi, along those lines, and Ali, we have a patient who had recently who had really severe CAV and then is going for a second transplant. I'm just curious, is a history of CAV on the initial transplant then a risk factor for recurrent CAV, so that you think that it's a host issue, or do you think it's an interaction between the host and the donor? I mean, like you said, recently with newer donor policies that you might be seeing less CAV. So I'm just curious if it's like an individual association between a host and a donor, or more donor driven. Just curious if you look at recurrent CAV in second transplants.
So there is a higher risk of CAV in retransplants, and of course, for a number of factors, retransplants have a worse prognosis than first-time transplants. I think it's a combination of those factors. It's not solely host dependent. Otherwise, of course, we probably wouldn't be retransplanting these folks. But it certainly, I don't know, Ali, if you have any more insights, but it's certainly a combination of both, like whether it's donor age and cardiovascular risk factors and things that occur like at the time of transplant and early on, whether or not they get rejection, whether or not they have long graft ischemic times and so forth.
Yeah, I think Rushi hit it on. I think there's host factors and there is high risk of vasculopathy, recurrence, and reduce for multiple reasons. So I think there's a higher surveillance rate, and making sure certain risk factors can be modified ahead of time would be done in the recurrent or in the repeat transplant.
And then just to quickly mention, right now our current standard of care post-transplant is aspirin and a statin, and even with the statins, they're not necessarily full dose because of statin-related rhabdomyolysis that can happen. So we kind of start at a low dose and then bump it up in certain patients based on their angiogram and IVUS. The fellows who worked with me yesterday, we had a case of someone who angiographically looked like they had clean coronaries, and sure enough on imaging, unfortunately at 1 year had severe CAV. And sirolimus is the immunosuppressive agent that we typically escalate to. And just wanted to point out that in the early 2000s, there were centers that moved to a sirolimus first approach, but that didn't work. Even though they had lower incidence of CAV, it has a lot of side effects related to poor wound healing and so forth, and worsening cases of infection. And so that strategy hasn't been out. So it's kind of like one of those games of whack-a-mole where once we see what's going on, we try and put a band-aid on it. But I think it really speaks to trying to go more towards prevention and look at the mechanisms and see if we can really detect it early, if we can institute earlier therapies really soon after transplant.
Thank you, Rushi. This was awesome. Very important for us. Just a few things. How did you define accelerated CAV? That's one question. And the other one is, did you try to measure these things once we change the therapies? Like if we go to high intensity statin and if we go to sirolimus, whether there is any change in the expression of endothelin? And then, should we measure these things and see? Because we all seen that it can stop in some patients if you change the statin and if you change the, the treatment with sirolimus. And then regarding the statins in the whole our community, the first study was done with pravastatin because the others are supposed to have reaction to tacrolimus. And if you ask on meetings, people will say never use Lipitor in these people because bad things will happen. But I don't think that that's true. because I mean, we have plenty of patients who've been on high intensity statin without any problem, but that's been one of the biggest hurdles for us.
Thanks, Darko, for the kind words. So I think your first question was about how we defined accelerated CAV. So, the 2D imaging studies, 2D IVUS studies looked at maximal intimal thickness, which is, again, just a 2D measurement. Since we were looking at volumetric or 3D analysis, we looked at those prior papers, the one from UCLA here by Tobis and Kobashigawa, and in both cohorts, both studies, about 20 to 30% of the patients had greater than 0.5 millimeter change. So accelerated disease, as we call it. And so we decided from our sample size to just, okay, say if it was 20 to 30% of those patients, we'll take above the 75th percentile of, lumen volume loss and call that accelerated. And that was how, because we had to, one option was to just take the median and just say, okay, the top 50% have accelerated, but we really wanted to try and mimic the prior papers as best as we could. And so we chose the 75th percentile. I think your second question was related to if I've looked at, or if we've looked at how endothelin levels change or expression changes with institution of sirolimus or other agents as we go along. That's a great idea. Unfortunately, haven't been able to do that. Because the numbers are, hopefully small. We don't do it that often, but I think it would be, over the course of several years that we probably could do that and accumulate enough data to take a look at and have a meaningful sample size. And I really think the other thing is, transplant community is small. Sample sizes are small. I mean, we're at a top 10 institution, and, after I weed out kids that get transplanted and dual organs and those that have kidney dysfunction, the sample size is, maybe 40 patients at UCLA a year. And so it really speaks to trying to collaborate with other institutions to try and get enough patients to actually meaningfully look at these things. And then I totally agree with you on statins. I've seen a wide variety of practice at the 3 institutions I've been at. And I'm not really sure where the evidence really lies. I think a lot of it is expert opinion, as you said.
Rushi, if I can, fantastic talk. I mean, I share everyone's sentiments. It's a very important work. And I know that you're still working on an observational sort of phase of looking at, endothelin levels and sort of more of a coronary anatomic atlas, as you all, of the transplant population we have. But I think I'm just curious to know, based on what you know of the drug and its properties, like how would you figure out a therapeutic dose equivalent for the coronaries? I mean, is that something you've been entertaining or looked at before? I mean, would it be the same? The drug that, obviously attacks both receptors is, it's used in practice as bosentan. So the question is, coronary physiology, I don't know, has the same sort of, reactions and effects for the doses that are used in PH. I'm wondering if you comment on, how you would frankly give it and at what kind of administration, IV or oral and whatnot, if you had your choice.
Yeah, great question. So when we wrote the grant, I sort of had some consultations with different pharmacists and also folks at, initially it was going to be at Gilead, but then who make Letairis, which is a selective, or ambrisentan. Unfortunately, they went off patent, so that kind of fizzled out. They didn't want to provide any more drug. So I moved on to Actelion, which is through Janssen, and macitentan is also like bosentan. It's a dual receptor antagonist. Their daily dosing is 10 milligrams, and sort of in consultation with them, and their pharmacists and our pharmacists, that seemed to be an appropriate dose for what we were trying to achieve. Now you're right, this is all going to be early pilot data, and then depending on how things go, there could be different, dose studies. They actually are going to be releasing a 75 milligram tablet they're studying, which really also attacks the ETB receptor. 10 milligrams kind of really inhibits the ETA receptor, which is the most important. But the good news is that, most of these patients, obviously pulmonary severe PAH is really a contraindication to heart transplantation unless you get combined heart-lung. So there aren't many patients at all that are on endothelin receptor antagonist post-heart transplant. So it will be a way in a new population. And so we'll obviously be doing a lot of safety analysis and stuff, but there's no drug-drug interactions that are obvious.
Thanks.
Any other questions? I guess I haven't looked at, is there any in the chat that I haven't looked at?
I think that's good. That was fantastic grand rounds, Rushi. Thank you so much.
Thank you for the kind words, Carol. I appreciate it.
Thank you, Rushi. Great job.
Thank you, Greg. Okay. All right. Well, thank you guys very much for your attention and questions, and I'll see you in the cath lab.